which is kind of a miscellaneous. So sleep stages, in general, there are 3 stages of sleep, and we categorize those into non-REM, and REM stands for rapid eye movement. So non-rapid eye movement and rapid eye movement. We spend the majority of our time sleeping in these non-REM stages. There's stage 1 when you're just falling asleep. Stage 2 is where we spend a lot of our time, most of our time. And then stage 3 are those nice, slow, deep waves. We call those delta waves. And that's where we get that deep restorative sleep. Then we go through these cycles. So we continually go through stage 1, 2, 3 REM, 1, 2, 3 REM. And as we progress through the night, if we're, in a regular daytime schedule, then we start having REM sleep, which is, once again, rapid eye movement. And it's where your mind gets very active. That's when dreaming occurs. Those cycles start having more REMs towards the end. So as you wake up and you're like, wow, I really had some vivid dreams, that means you were able to get more REM sleep. And then you can remember your dreams a little bit more. Sleep is really, as I said, we're going to go through this more. I'm going to try not to get on a tangent, but sleep is everything, you guys. Having good sleep helps you maintain good metabolism, maintain good cardiac function, maintain your cognitive ability. So one of the things you guys will, hear me saying is, don't pull all-nighters to staying up and studying. It's not going to help, because a lot of your memory consolidation and a lot of your cognitive functions happen when you get restored with your sleep. So just a second here. Sometimes people text me because they need to get in. So let me just check this. Okay, let me stop and see if somebody's trying to get in. There we go. Okay. There we go. Okay, there's Kaya. Okay, Kaya, can you hear us?
Her microphone's off. Oh, okay. Sorry. Okay.
There we go.
Welcome, Kaya.
Thanks.
Okay, so we'll continue back on. Right. Okay, so anyway, we in order to get healthy, restorative, deep sleep, we need to go through all of these sleep cycles. So people with sleep disordered breathing have impairment in either multiple cycles or the REM. So, we'll talk about that. So from a physiologic standpoint, when you are sleeping and you're in your non-REM phases, you have muscle tone, meaning your muscles are still able to maintain the posture and hold your airway open. Your tongue muscles, your throat muscles, the pharyngeal muscles, are really working like they're supposed to. However, your minute ventilation does naturally go down because you slow down your breathing and you're not needing to take really deep breaths. So therefore, your PaCO2 will go up slightly, and that's okay. Your blood pressure will go down. And then this is a real bummer. We already said the non-REM stage 3 is when you get that deep restorative sleep, and that naturally, that phase actually decreases with age. So as I said, that's kind of a bummer.
Mm-hmm.
Physiologically, looking at your REM sleep, it's a little different. So you do not have as much muscle tone. So you can see why at that phase, if your pharyngeal muscles aren't working or they're not as toned as they should be, what's going to happen? When you start going into REM sleep, you could easily obstruct your airway at that point. You naturally become a little bit more hypoxemic. You naturally become hypercapnic, meaning your CO2 goes up. You then have more airway resistance from a decreased lumen in your upper airway from the lack of muscle tone. You can have cardiac arrhythmias, and your blood pressure can vary. And that's because this is a very active stage of sleep. Now we need to look at some vocabulary terms because this will help you understand just the terminology. So when one uses the term hypopnea, and that's low breathing, it is a reduction of airflow between 4 to 50% of our baseline airflow for at least 10 seconds with at least a 4% saturation drop, or an EEG arousal greater than 3 seconds. So we've talked about ECGs, measuring the electrical activity in our heart. When we talked about neuromuscular, we talked about EMGs when we measure the electrical activity in our muscles. And now we have the term EEG. So that's an electroencephalograph, and that's looking at the electrical activity in our brains. Apnea is greater than 50% of airflow reduction. Okay, so just when you're maintaining your baseline airflow in apnea, that's reduced to at least 50% of that baseline. Respiratory effort-related arousals is similar to hypopnea minus the airflow reductions. Okay, so when you have these, take, for example, if your saturations drop, a lot of times that'll wake patients up because they're suffocating. Or upper airway resistance syndrome, where there's repetitive increase in resistance to our airflow in our upper airway, leading to brief arousals during sleep. So once again, we spend the majority of our time in the non-REM phase 1, 2, 3, 4, and then we go into our REM sleep. So the majority of our time is non-REM stage 2. And then in our REM sleep, we have dreams. They last anywhere between, just kind of depends, but 5 to 40 seconds. We have what are called alpha rhythms, which are smaller and more active brain rhythms as compared to the slow delta waves. We have a rapid respiratory rate. It becomes shallow. We can even hypoventilate and have periods of apnea.
I have a question. So when we sleep and we have dreams, all that happens within 5 to 40 seconds?
Yeah, but we go through multiple cycles of it. Yeah, it's crazy how it could seem like this really long, drawn out dream. That could be a 10-second dream.
Crazy.
I know it is, isn't it? You guys, the field of sleep is, it's kind of boring when we think about it just from a quick standpoint, but there's so much to it, and it's actually really interesting. As I said, we'll get into this next semester, but there are things called parasomnias where people sleepwalk. Narcolepsy is really common, but as I said, we're just focusing on the sleep disordered breathing that we treat. So when we have a decrease in our muscle tone, we have a decrease in our functional residual capacity because of the decrease in intercostal muscle tone, paradoxical movement of the thorax due to diaphragm generating that change in pressure. So remember, the functional residual capacity is always that balance between our lungs naturally wanting to collapse and rest versus our thorax wanting to expand. So that pressure difference is what creates that functional residual capacity. The loss in muscle tone also causes airway obstruction due to the loss of upper airway muscle tone. And then in general, there's 3 types of sleep apnea. Obstructive means the upper airway obstructs on inspiration. Males have this more commonly than females. It is associated with shorter necks. The central sleep apnea is when the medulla fails to send signals to the muscles to actually take a breath. There's no inspiratory effort. And so it's not that, like on the obstruction, when they're trying to take a breath. In central sleep apnea, it's a neurological issue. But then you could also have mixed sleep apnea, where it begins as a central sleep apnea, and then when the brain finally does tell the body to take a breath, then the patients obstruct as well. So commonly what we're going to see in the number one, not the most common type of sleep disorder, but the number one type of sleep disorder that requires management and therapy is obstructive sleep apnea. And so that's what we'll deal with a lot. So non-cardiopulmonary manifestations of sleep apnea are, of course, snoring, insomnia, daytime fatigue is a big one, depression, personality changes, sexual dysfunction. So all of those are just from not getting enough sleep and not being able to, if you think about it, just think if, you don't get sleep for a night and how irritable you are and just how exhausted you are. And you just, you can't get those good feeling neurotransmitters, the dopamines that really help you feel good. A polysomnogram is the test that actually diagnoses obstructive sleep apnea. So it is what's called a montage or an arrangement of at least 17 sources of physiologic data taken from the patient's head and body. So the patients have EEG electrodes on them. There's an EKG electrode on them. The EMG measuring like muscle kicks. You're measuring saturations. You're measuring baseline flow. So you're really just looking at everything the patient is doing during sleep. And what you're looking for then are what we saw before, those apneas and hypopneas and any of those respiratory related arousals. So one of the biggest takeaways that you guys need to understand from today is just like when we've objectively measured through spirometry, see, is it restrictive or obstructive? Of course, there has to be some sort of objective measurement to say, does a patient have obstructive sleep apnea? And that is done through the apnea-hypopnea index. And it's the number of hypopneas and apneas per hour of sleep time. So for adults, an AHI, an apnea-hypopnea index greater than 5 within a 4% drop of the baseline SATs says that they're having abnormal breathing and they need treatment. In pediatrics, it's greater than 1 with an increase in their end-tidal CO2 or a saturation drop greater than 92%. So in general, 5 to 15 apnea-hypopneas per hour says it's a mild obstructive sleep apnea. AHI 15 to 30 is moderate and greater than 30 is severe. So can you imagine going apneic or at least almost apneic, hypopneic 30 times per hour when you sleep? That's pretty bad. And your body will really feel that effect of not getting oxygen to the tissues at that point. So management, of course, before lifestyle changes are recommended before you start doing other things. So weight reduction is always the number one lifestyle change someone can do first. The problem with weight reduction is it's kind of a vicious cycle. So it's easy to say, oh, well, the patient should lose weight. But if they're not getting good sleep, what happens to their metabolism? It goes down. And so then they not only don't have energy to exercise, they don't have, as I said, the energy to exercise, but also they'll crave more quick energy foods like the processed carbs. And then that, of course, that contributes to the weight gain as well. So without that good sleep, your metabolic system is really impaired. Sleep posture. So of course, if you are laying supine on your back, you have a much higher chance as compared to laying on your side of having obstructive sleep apnea. Patients a lot of times can just oxygen therapy alone, just that flow of oxygen will help patients. And you can determine that through the POLYSOM test. Different types of drug therapies, like tricyclic antidepressants might help. They're like REM inhibitors, but medications is usually not always the first recommendation. There are different types of surgeries to reduce some of the swelling and some of the tissue, and then mandibular advancement devices, and a lot of times that'll come through like dental practices, and that's where you try to move the mandible forward or maybe get some sort of a mouth guard to try to help. However, it says in big red letters, most patients need positive pressure. So this is where CPAP, some patients might need continuous mechanical ventilation or non-invasive positive pressure, and that's more for the patients with central sleep apnea. Sometimes when patients have central sleep apnea, they'll have to have a trach and continuous mechanical ventilation. But the CPAP is the #1 therapy to help patients sleep with obstructive sleep apnea. Some newer things that are happening are phrenic pacing. That's starting to gain, I think in Europe it's a little bit more popular, and they're starting to test it out here in the United States more as well, but not proven yet, not as popular as just good old fashioned CPAP. And then a tongue retainer just to kind of help bring down the airway resistance in the oral cavity. So when we're looking at CPAP, what's really nice is all of the different, I'm going to have you look at me for just a second. So
Grandpa was supposed to have that, and he actually can't wear it at night, so they just switched him to oxygen.
Okay.
And he's always tired during the day. It's like, you need to wear that.
Right, exactly.
Yeah.
So I have a variety, and the nice thing now is that there are a variety of masks. So this is just a small nasal mask, okay? And this one, of course, just fits right over the nose. And I think this would be a more popular choice as compared to a big full face mask like this one. There are other ones that I didn't bring home with me that are called nasal pillows that just comfortably sit. And it's almost like a really big nasal cannula. And then there's ones that are like full scuba masks. And I might have one of those. Yeah, well, no, this one's still just a, this one is just a full face mask as well. But anyway, there's also as I said, this big scuba mask that looks really invasive, but a lot of times patients tolerate that. So it goes all the way around their face. So it really is patient preference. Whatever the patient wants to use, the better. So as I said, there's really nice ones these days. And then of course, can somebody describe CPAP to me? How do you think CPAP is going to help these guys or women? I don't mean just guys.
By forcing the air to kind of open up that upper airway.
Exactly, Christine. That's exactly right. So of course, I have my little CPAP machine, and as I said, well, this one is one that would be more used in the hospital. If patients were going to go home, they would go home with just a little box CPAP, just a really small box CPAP. So can you guys see my test lung here?
Mm-hmm.
Okay, so I have this on what's called CPAP, continuous positive airway pressure. So it is not giving breaths. This does not assist in ventilation at all. The only thing it does is it forces air in the airway at all time so that patients cannot collapse collapse their airways. Okay, I have this on a really low setting. This is like 5 of CPAP, so this is really low. So what I can do is I can go all the way up to 20 of CPAP. You guys can probably hear the difference. And then can you see the difference on how much more open? So it's giving a significant amount more flow, and it's really keeping this lung open. Okay, so then when the patient does take a breath, they can definitely breathe over, on this pressure, but their lungs will not collapse. This also goes down into the airway and helps so that the airway doesn't collapse as well. Okay, so that's our CPAP machine. That's literally how the CPAP functions. Just as Christine says, it just literally pushes air through so that when the patients are sleeping and they have the tendency to collapse on inhalation, it won't allow them to. Okay, so what has to happen is, first thing, when you get screened for obstructive sleep apnea, you can actually do a home test. You don't have to come into a lab. You can go home with just a couple of, like 4 different physiologic indicators that they'll see, and then they can screen you and say, oh, you do have multiple AHIs. Okay, you probably need some therapy. So then they can put the patient on different CPAP levels until the AHI index comes down. So that's how they can see if, like, is oxygen okay, or do they need 5 of CPAP? Do they need 8 of CPAP? Do they need 12 of CPAP? So it's when they stop having those apnea hypopnea indices is when they know that the CPAP is treated. Okay, and that is not something you can do at home. That's where you would, if you were a respiratory therapist working in a sleep clinic, that's what you would be doing, is providing that positive airway pressure.
What's that nasal thing called again?
Okay, those are called nasal pillows.
Hello.
They look, I think that, hey, if I was going to be on CPAP, I think a nasal pillow would be a good choice for myself.
Okay, thank you.
Okay. So if you are a respiratory therapist, there's another whole credential called the SDS, the sleep disorder specialist. So that's another whole credential that you could get after you get your RRT, and if you wanted to specialize in sleep medicine. Okay, so it's a great field, very interesting. Another big thing that RTs do is called mask fitting. And as I just showed you a couple of masks, there's so many different masks, and you might use like something like this to really see what size a patient needs so that you get a really good fit for the masks. And that adherence to therapy is one of the biggest challenges with obstructive sleep apnea. Like Beverly, you just said that, somebody doesn't like to wear their mask. A lot of people don't. My dad is supposed to be wearing his CPAP machine, and he doesn't. So he's too stubborn.
Yeah, there's no change in their minds. So
No change in their minds. With screening for sleep apnea, there is a variety of objective measurements. This one here is called the Berlin questionnaire for sleep evaluation. There's the Epworth, is very common. There's another one called Stop Bang. So there's just a variety, and those are looking at different indicators of daytime fatigue, gender, because of course males have it so much more, and then looking at neck circumference, and then BMIs, body mass indices. So let's just do a little quick quiz here. Multi-channel polysomnography helps in the diagnosis of what?
Obstructive
what?
sleep apnea.
Yay. Okay. The diagnosis of obstructive sleep apnea is diagnosed based on what index taken from a polysomnograph?
Apnea, hypopnea.
Yes, index, AHI, apnea hypopnea index. And what AHI indicates mild disorder? At least an AHI of what says, hey, I have a problem.
Isn't it
5.
5.
Yep. And then what do we consider severe? Anything greater than what? 30? Yes, 30. Okay, what would be the most appropriate recommendation for a patient suffering from obstructive sleep apnea?
Is it CPAP?
Yes. Being treated with CPAP. Very good. And what are some clinical signs and symptoms associated with sleep apnea?
Snoring.
Snoring. What else?
would it be the the fatigue and the
Daytime fatigue. Yep. So generally it's the snoring, but also like the partner will say they don't just snore, they like stop breathing. So it's usually the partner that'll say that it's, they have a pretty bad condition. And then it's just the continual fatigue and the daytime drowsiness. They just never feel like they get a good night's sleep. Good. Okay. Okay. So this one's kind of interesting. Little iron lungs. What was an iron lung used for? Anybody have any idea? So an iron lung was our very first ventilator. Okay, so you put a patient in these chambers and you pretty much hooked up a vacuum to these chambers, and that was a negative pressure ventilation. Okay, so this started during the polio epidemic in around the 1950s, and then ventilation has really changed since then. So this was negative pressure ventilation, and now we use positive pressure ventilation. So smoke inhalation. This is chapter 42. Yeah. So smoke inhalation and burn injuries. So as you can see, when you inhale anything smoke related, it really is going to cause a lot of irritation to the entire tracheobronchial tree and in some cases to the lungs as well. So this is a patient with a smoke inhalation. If you guys can see the kind of the ground glass or the bilateral infiltrates, and then they actually recovered. And so they actually did a little bit better within 72 hours. So you don't see a huge difference, and they didn't go into full, what respiratory if somebody gets smoke inhalation and burn in their lungs, what do you think what pathophysiology could they go into?
Interstitial lung disease.
Okay, so it could be that, but what else? What usually happens? What respiratory disorder happens as a result of an acute injury? Anybody?
Could it be like atelectasis?
Well, so they'll get atelectasis, but what do you think? What happens when you get some sort of an acute injury and your lungs get irritated and they start having cytokine releases, and then they start getting stiff, and then fluids, ARDS, ARDS.
ARDS, duh.
Yeah. So when a patient, commonly when they have an inhalation burn, they go into ARDS. Okay, so there's fire-related pulmonary injury, so thermal inhalation of hot gases or smoke, or there's actual distal airway and alveolar involvement. So you can pretty much get singed, your tracheobronchial tree, or you can actually, if it's, you know, if it's a real smoky fire, get irritated all the way down into your tracheobronchial tree and into your lungs. So this one's really important. The classical predictor of thermal burns is the presence of facial injury. Okay, so when you actually go to your book, this is one. There's a lot of graphic pictures because burns are really tough. But on page 977, they have a picture of a burn injury, and then they have some really cool pictures through bronchoscopy as well. Ooh, page 981, there's first through fourth degree burns on a child, and of course it's hard to see, but kids are always into everything, so they do get burned on occasion. There's pictures of the airway that's burned, and then there's pictures a bronchoscopic injury from a burn. So check that out. It's really interesting. But yeah, the classic predictor of injury to the tracheobronchial tree is facial burns. Okay, thermal injury to the upper airway results in blistering, mucosal edema, vascular congestion, epithelial sloughing. What do you think what does that sound like? What does the term epithelial mean anyway?
It's a good type of tissue.
Yeah, tissue. Good. And we say sloughing, that just means it's coming up. It's literally detaching. It's being burned off. Okay. So you know, that's really hard to have a nice patent airway when you have epithelial sloughing. And then of course, accumulation of thick secretions. Prognosis, of course, just depends on the duration, extent of the smoke inhalation, what was in the burning. Okay, the more chemicals, the worse off patients could be. Size and depth of the body surface burns, temperature of gases inhaled, age, and then of course, pre-existing health. Here's just a picture of the body surface area similar to one in your book, and it just shows you know, as you can see, look at the age in years here. So a 1-year-old, look how big their head is compared to the rest of their body. It's 19% of the total body surface area. And adults, our body catches up and it's only 7%. You know, but other big areas are trunks, our legs, and you know, our chest. It's a very big portion of our body surface area. So first degree burns, minimal depth, damage to the outer layer. There's reddened skin, no blisters, 6-day healing time. Just think of a good old sunburn. Second degree gets worse and there's blistering and it takes longer to heal. And then third degree is where the epidermis and the dermis gets destroyed. It takes a lot longer than 3 weeks to heal, and it can leave a lot of scars. So as I said, here's some pictures. There's really good ones in your book as well. But just think of the pain associated with burns. It's kind of hard to see. Well, some of the other things that happens is when you are in say a burning building, or you know, anytime there's fire happening, carbon monoxide commonly gets released. So if we remember, carbon monoxide has 200 times greater affinity for hemoglobin as compared to oxygen. So hemoglobin, heme sites, the iron sites and the heme group in the hemoglobin loves to bind with carbon monoxide. So, oh, what happened here? There. So if we have a carboxyhemoglobin of less than 5%, that's normal. It should be less than 5%. If we smoke consistently, cigarettes or whatever, especially cigarettes because they have a lot of carbon monoxide added to them, our carboxyhemoglobin level will be up around that 5 to 7 range. And you can actually test somebody's carbon monoxide as well as just the nicotine in their body. But if you really want to say, hey, are these patients stopping smoking or not, you can actually look at their carboxy levels. Greater than 20% means they're going to have symptoms related to carbon monoxide poisoning. Greater than 40%, it's going to be severe, and greater than 50%, they're going to have extensive central nervous system damage.
What does central nervous system damage look like?
Patients will be, their drive to breathe will be completely knocked out. Think of really low Glasgow coma scale. So they just do not have, they're not responsive. So yeah, just think of coma.
Can they come back from that?
Yeah, if they get properly treated, and it always depends like on the severity and the extent of it. So the first thing with carbon monoxide poisoning is you right away put them on 100% non-rebreather mask and try to where the oxygen will kind of the high concentration will push out the carbon monoxide. So that's what you do first, is just put them on high dose oxygen. But a patient with greater than 50%, just think about that would mean like your true saturations are around 50%. So if it gets caught and treated quickly, it could be reversible. But if they've been 50% for a significant amount of time, and then what do you think would happen then? They might take anoxic injuries to the head. They're going to have heart damage. They're going to have lung damage. They're going to have kidney damage, intestinal damage. So they'll just go into multi-organ failure. Okay, other types, cyanide poisoning. It can occur when there's burning of plastic material. And you guys, more than anything, remember that's the histotoxic type of hypoxia. And that's where the tissue cells are prevented from consuming oxygen. Cyanide inhibits cellular respiration, causing an increase in lactic acid. And then the O2 consumption may appear normal, but the cells themselves, because they're not uptaking the oxygen, will be extremely hypoxic. So cyanide levels of greater than 1 milligram per liter is usually fatal. Okay, so management of any of any burn or thermal injury would be fluid resuscitation. What is that? We've heard that before. What does the term fluid resuscitation mean? It just means that they're receiving IV fluids via crystalloid or just a normal saline. So they're really getting their fluid balance back to normal, which will help all of their functions and their acid-base status. Of course, patients are going to need oxygen and positive pressure, especially if they have respiratory failure. You're going to need to monitor their electrolyte balance, airway management, a trach if the airway can't be established otherwise. If they have significant burns to the tracheobronchial tree, that can be pretty devastating. Oops. And then bronchoscopy is commonly used to go down and wash out a lot of that epithelial sloughing, and then also to assess the damage of the tracheobronchial tree. So let's check for understanding. Here's your next quiz. A carboxyhemoglobin level of greater than 25% will correlate with what patient symptoms? What do you guys think?
Carbon monoxide poisoning?
Yeah, what patient symptoms?
Oh.
So if 25% of your oxygen receptors are blocked, what do you think you're gonna have for symptoms?
Probably hypoxemia.
Uh-huh. Yeah.
Increased work of breathing.
Yes.
Headache?
Headache. Very good. So a headache and fatigue and fogginess. So, those are the headache and fatigue are the first signs. And then as it gets worse, you're going to have to give oxygen, positive pressure ventilation, airway management, initiation of mechanical ventilation. So the therapist will suspect injuries to the tracheobronchial tree in a burned patient based on what common finding?
Facial.
Facial trauma.
Good. Facial burns. Good. Good. Okay, this is a really good one. Can pulse oximetry adequately measure for saturation during carbon monoxide poisoning?
Hell
No.
no.
Yeah, very good. What test will you additionally have to do?
Carboxyhemoglobin.
Okay, good. And how do we do that? Through what? You guys remember what it's called?
Is it the ABGs?
Well, no. So an ABG won't measure.
Oh, it won't
You have
measure.
to send it specifically for a hemox
It's
a
like
hemooximeter. Okay, so it has to go down for testing to see all the different types of hemoglobin, not just one type. Because remember, the pulse ox, like you guys said, it just says, "Hey, are my hemoglobin sites bound?" Sure, but with what? Okay, so you're gonna have to send that down for extra analysis.
What is that test called?
A hemooximeter or a hemoximeter.
How does that work?
Okay, so it actually there's a couple of types. So like firefighters have like a non-invasive one, like on their trucks. So it looks at different levels of light spectrometry. So it'll look and actually see what type, and it'll distinguish if it's oxyhemoglobin, carboxyhemoglobin, or methemoglobin. So it'll look at all those different types. So as I said, the fire department has one that'll look at the different spectrometry on it, and then, or you can send it down to the lab for blood analysis, and then it'll just say here, and it'll distinguish what type of hemoglobin you're actually seeing as compared to just, oh, it's 100% saturated. So that's something that you'll definitely want to think about, because if you have somebody in a burning building, you're really going to want to check their carboxyhemoglobin level, and you're going to want to provide them with the highest amount of oxygen possible. So right away, if they come into the emergency department, you'll throw them on a non-rebreather mask. And just try to let them soak up all the oxygen as possible. And then if they're not responding enough, you draw an arterial blood gas and they're in respiratory failure, they're high CO2, then you're going to have to intubate and mechanically ventilate them as well. Drowning. So there are different types of drowning. There's, of course, we can't say if we're treating a patient that they have drowned, because that would mean that they're not still with us, but we can say they have near drowning, okay? And that just means they survived the submersion incident. There's also dry drowning, in which the glottic spasms and no water gets into the lungs. However, do you guys remember like I think it was 2 years ago, a child died of dry drowning, and then everybody was terrified of it, and that was like the new term. Does anybody remember that from like 2 summers ago?
Yeah.
Okay. It's kind of a controversial term, because it isn't really like, oh, that's what really happens. It just means that somebody was hypoxic for a while and they didn't get submerged with water, but they had complications of their hypoxia. So they kind of term that dry drowning. Wet drowning is classically what you'd think of. Water gets into the alveoli, causing the non-cardiogenic pulmonary edema, decreasing surfactant, atelectasis, and frothy secretion. So pretty much patients go into ARDS. Okay.
So for dry drowning, that doesn't really mean that it's like near water or anything. It's just like while you're
no. Okay, so think about if somebody, so it is associated with drowning, okay? So it is associated with somebody getting submerged. And of course, and we'll talk about this in a minute, who gets submerged, so children a lot of times. So they get submerged in water and start gagging and having, the response, but their glottis stays closed, and so they don't ingest a large amount of water. but it is associated with like a hypoxia. Okay, so it is associated with water, but it's just that they don't get a lot of water down into their lungs.
Gotcha.
That is a controversial term. A lot of times people say that's not even really real, but you'll commonly hear it, so it's real to us, right? So there's different types of drownings. So warm water drowning occurs at water temperatures of 20 degrees Celsius or higher. Cold water drowning occurs with less than 20. Ice cold water has been reported to be protective, and especially in young children. Does anybody have any idea why?
Slows their metabolism down, or slows all the processes down.
Yep. And then it shunts all the necessary oxygen consumption to the main organs only. Okay. So that's called the human dive, or the mammalian dive reflex. So if you're going to drown, you need to drown in ice cold water. You have a better survival for children anyway. Prolonged immersions can nullify any effect of temperature on survivability. So the longer you are submerged in water, the worse outcomes is more likely. So infants are more often or commonly occur or drown in bathtubs or bucket of water because, you know, they can't swim. Children 1 to 5 more commonly drown in swimming pools. And then young adults typically drown in ponds, lake, rivers, and oceans. They're actually going out and trying to swim in areas and something happens. So the degree of the central nervous system injury depends on the severity and the duration of the hypoxia. If you talk about a post-hypoxic cerebral hypoperfusion may occur, and cerebral hypoxia inclusive vegetative survival is the most devastating. So just think of somebody that for a long period of time doesn't get oxygen to their brain, and they live in a constant vegetative state. So that's the worst complication of drowning.
So is that ABI kind of? Anoxic brain injury?
Yes, it is. Yes, very good. Yep. So in general, the drowning or the near drowning sequence happens. There's panic and a violent struggle to get to the surface. Then there's calmness and apnea. Then there's a swallowing of large amounts of fluid. Then there's gasping inspirations and aspirations. And there's convulsions, coma, and death. So different pathophysiologies really depends on what the fluid content of the water is. So if it's fresh water, there tends to be destruction of the surfactant, and that can lead to atelectasis, decrease in compliance, and BQ mismatching. In saltwater cases, it draws fluid into the alveoli, washing out the surfactant. You get exudative proteins into the alveoli themselves, leading to decreased compliance, alveolar capillary membrane damage, and then a lot of shunting. So it's all bad, but it just kind of depends on what the content is. Kind of changes the pathophysiology a little bit. Complications, of course, ARDS from altered surfactant can affect. And pulmonary edema commonly complicate drowning in survivors. Pneumonia is common with submersion in stagnant water that's warm and fresh, because there's a lot of different microbes in that live there. But of course, central nervous system injury remains the major determinant of survival and long-term morbidity in cases of drowning. 2 minutes after immersion, a child will lose consciousness. Irreversible brain damage usually occurs after 4 to 6 minutes. Most children who actually survive are discovered within 2 minutes of submersion. So it's pretty bad. Most children who die are found after 10 minutes, and primary CNS injury is initially associated with the tissue hypoxia and ischemia. So drownings are hard to take care of. You know, I worked at Children's for years, and some of the worst cases are those near drowning patients, just because they're like normal, healthy kids, and then they come in and then they have a severe CNS injury, head injury. So of course, management, remove them from water, begin really good, high quality CPR. Submersion for less than 60 seconds with fixed dilated pupils is not a poor prognostic indicator. So if they're submerged for less than a minute, they usually have a pretty good chance of survival. Remove the wet clothes, replace with dry clothes. Why do you think that is? Why does it matter?
Body temperature.
Body temperature. So something else you'll learn when you work with patients and when you're in trauma is a cold. They say a cold patient is a dead patient. So you can't even pronounce patients dead until you bring up their core temperature. Managing during transport, of course, quality CPR with 100% oxygen, conserve the victim's body heat, so keeping them dry. And then at the hospital, it's monitor for acute ventilatory failure. They usually need to be intubated and ventilated. Of course, when with a lot of PEEP, inotropes and diuretics to keep their heart working well and to get rid of the extra fluid. Heating blankets and warm baths. So these patients, you'll want to get heating blankets on them. You can also warm the fluids that go into them, and then also you can bag valve mask with a warmer, and that's something that we used to do at Children's a lot with these trauma patients. So the gas that you use is heated.
Is that like the heater like the donut heater?
Yes. So
Yeah.
it's well, no. So a donut heater is it's still a heater, so they're just different types. But when you would warm the gas, you would actually have to use the heaters that you would use for mechanical ventilation, like the just the warming plates heaters, and then you run the water on that heater, and then you run your flow of oxygen through that heater. So it warms the gas as it goes along.
Gotcha. Okay.
Yeah, good question. And then, of course, ECMO with cardio bypass if needed. And that's extracorporeal membrane oxygenation. You guys might have heard that. They're using that with a lot of, COVID patients as well. And that's a bypass for the heart and lungs. So here's a patient with submersion. You can see it's, of course, it's that all the water and whatnot settles down into the base of the lungs. What is the most severe complication in a near drowning patient?
How long they're submerged?
Well, complication.
ARDS.
Okay, ARDS is bad, but it's not worse than this. What do you not want to come out with?
CNS injury.
Yeah. You don't want to come out with a severe brain injury, do you? Yeah, that would an irreversible brain damage. That means you would leave one in a vegetative state their whole life. So yeah, that's definitely the most severe complication. Okay, so distinguish between dry and wet near drowning.
Well, dry is when you're submerged in the water, but you don't inhale a lot of water.
Correct. Very good. And wet, you obviously do. And it causes lots of complications with the lungs, including ARDS and pneumonia. Very good. What is the initial goal for a near drowning patient?
To find them within a minute.
Okay. And what do you want to do with them? When you're talking about treatment, what do you want to do with them?
Give them oxygen.
Good. So not only oxygen, you want to get them out of the water and do high quality what?
CPR.
Good. High quality CPR with 100% oxygen. Very good. Very, very good. Excellent. Okay, you guys, this is the very last thing that we're going over for the whole semester. New thing. Yay! Okay. And this is chapter 39. So this is called post-operative atelectasis. Okay. And so what happens is the lung parenchyma, for some reason, there's multiple reasons, gets collapsed. And so gas exchange does not take place. So when you're looking at preoperative management, you want to get a good preoperative history. So think about any lung complications that we've talked about before are going to predict the patient will have more complications. PFT screen, the best predictor of post-op pulmonary complications, is looking at that patient's FEV1 value, the forced expiratory volume in the first second. Okay, looking at bronchodilator use and maybe do they take consistent bronchodilators? And then monitor serial, meaning continuous respiratory rate, vital capacity, tidal volume, and arterial blood gas. So post-operatively, what happens with patients after they've had surgery is they don't take deep breaths and cough. Why not?
Hurts.
It hurts, exactly. Anytime you have surgery, you're going to have pain. And what breathing pattern is associated with pain? Shallow and rapid. And when we have rapid and shallow breathing, do we get good gas exchange and opening into the lungs, or does it mostly stay in our anatomic dead space zone? Mostly stays in our dead space. That's right. So it doesn't go down in and inflate the lungs. So hyperinflation protocols are crucial in post-op patients. Now, I don't mean every post-op patient. I mean, most of us that have surgery are totally fine. But if you have any underlying condition, you have any underlying disease, think about a neuromuscular patient. They really struggle after post-operative because they can't deep breathe and cough. So hyperinflation protocol, give me 1, 2, 3 different modalities of what we mean by hyperinflation protocol. What does that mean?
Like you're expanding the lungs.
Exactly. Very good. Be specific. Can you name me 3 or 4 hyperinflation techniques? How can you do that?
Like breathing out hard or like forcefully. Like do like a flutter valve.
Learned them in lab. So what are the hyperinflation protocols you guys have learned?
Metaneb.
Good. Metaneb is one. Very good.
Yes.
What's that?
Yes.
Yes. Incentive spirometry. Very good. What else?
Is that like the acapella?
Okay, acapella is more for, I mean, yes, exactly. It's more for airway clearance. So incentive spirometry, the Metaneb. How about those weird IPPB machines?
They're so weird.
They're so weird. That was the very first mechanical ventilator. So I know they seem weird, but they're just like basic ventilators. Good. And then how about your little easy PAP machines as well? Okay. So anything that's just going to provide consistent positive pressure is your hyperinflation. So
could you use CPAP for that as well?
Okay. Perfect. Yes, absolutely. You can. So if a patient is, let's say they have pretty bad obstructive sleep apnea, if they have pretty bad obstructive sleep apnea and they have a CPAP machine during the day, if they're sleeping, you might want to just provide some CPAP with rest.
Okay.
In neonates and pediatrics, and when I say neonates and pediatrics, I mean babies, because if you guys have ever had toddlers, they would never let you do this. But one of the ways that we used to provide hyperinflation for babies is just literally hold a mask. So we would literally go in and just give them mask CPAP every couple hours and make sure they're inflating the lungs.
Okay.
That's CPAP. Okay, bronchodilators when indicated. What's an indication for a bronchodilator?
Like rapid breathing.
Okay, but that could be from anything.
Oh, that's true.
That's true, yeah.
Asthma.
Yeah, specifically. So absolutely, but what is it about the asthma that is an indicator for bronchodilator?
Inflammation.
Okay, not inflammation.
Wheezing.
Wheezing from bronchoconstriction. Good. Okay, we can't. Yeah. So that's very good that you said inflammation. What's indicated when there's inflammation?
A bronchodilator to vasodilate the.
No. So inflammation is from what? Inflammatory cells. So what's an anti-inflammatory?
Corticosteroid?
Yeah, a steroid. Okay. So a bronchodilator is indicated when there's bronchoconstriction. And vasoconstriction, that's when you need a vasodilator. So what's the difference between broncho and vasoconstriction?
Bronchoconstriction is in your lungs and vasoconstriction is in your arteries.
Good, in your vessels. Yeah. So bronchioles versus arterioles. Yeah. Good. Okay. Reassess oxygen requirements. A lot of patients will need just basic oxygen when they come out of surgery. And then incentive spirometry, cough, and deep breathing. Or what are you guys learning in equipment right now? What are you guys at home trying to do on each other? And I hope you don't.
Suctioning.
Yeah, suctioning. Yep. I heard you guys have been suctioning yourselves at home. Is that true?
No.
Oh, darn it.
We are trying ABGs though. I'm just kidding.
I know. I'm like, really? Suctioning and ABGs at home? This is ridiculous. So we're gonna be working on those when we get back to school. Okay. And then lung expansion is key to post-op. So post-op is simple. You need to make sure that you're supporting their oxygen and then inflating those lungs, no matter what that means, okay? The more underlying conditions and the lower the patient's FEV1 preoperatively, the more support they're going to need post-operatively. And it is really important to know when you're working in a critical care unit, usually the charge nurse will come to you in the morning and say, okay, these are our scheduled surgeries. And then you can look through and say, oh, okay, it's this patient, it's this patient. And then you'll know how many ventilators to get ready for the day. So if you have 3 patients that were, neuromuscular patients getting a spinal surgery, guess what? They're probably, you don't know for sure, but they're probably going to come back after getting their surgery to the intensive care unit intubated. All of us, and Taya, you know this because you work in one of these units, all of us, after we get surgery, where do we go?
PACU.
PACU. We go to this unit that you've probably never seen unless you work there, called the post-anesthesia care unit. And that's where the nurses and then the anesthesiology will say, hey, this person's vital signs are doing okay. We're going to wake them up and extubate them. Well, if they can't do that, they'll send them to the ICU, and that's when you get them and you get to manage them. Until then, you can wean them down and extubate them. Sometimes, and I wish they'd pay us like anesthesiologists, but sometimes you do even have to go into the PACU. When I used to work, they'd run out of, if the patients couldn't get extubated within a certain amount of time, they would call us into the PACU and we would have to come in and try and wake the patients up and extubate them in the PACU. So it's pretty interesting. Okay. What respiratory therapy treatment protocol is indicated for postoperative atelectasis?
Lung expansion.
Yes. Yep. Lung expansion. Excellent. What's another one that they might need?
Cough.
Okay, that's part of lung expansion. What's the most common medication that you're going to give?
Oxygen.
Yes, oxygen therapy. Very good. Okay. And then we already talked about this one again, but please find multiple modalities related to this protocol and describe their instructions and use. So this one, of course, was the incentive spirometer. So when you guys do an IS, what patients are candidates for incentive spirometry?
Post-operative patients?
Good. Post-operative patients, patients that are cognitive or not cognitive?
Cognitive.
Cognitive.
Cognitive. Why? Think about when you guys, I mean, I walked in and saw you guys all dying laughing. Did you guys have, when you guys were instructed on IS, did you guys all do it perfectly the first time?
No.
How many people tried to blow out into it?
I think only one.
Okay. Well, anyway, that happens. That's common. Okay. When you tell some of the things you can tell patients is breathe in like you're sucking through a straw, trying to drink a milkshake, because it's, you know, you really got to think about pulling that air in and trying to expand the lungs. So patients have to be alert and cognizant to do incentive spirometry. The IPPB machine, that's good for patients that can't do incentive spirometry. There's only like 2 hospitals in the Denver metro area that you're going to use IPPB, but you still will. So if you go to Craig Hospital or if you go to the VA hospital, they do still use IPPBs. Newer mode, and that's just positive pressure. That's just giving patients positive pressure ventilation. You can also give them a nebulizer at the same time. Other modality is the MetaNeb, which is fantastic. So it breathes in pulses of continuous positive airway pressure, as well as does the little pulsing. So it's good for both lung expansion and airway clearance. Very nice little machine. And then an EasyPAP machine is, we have those in the lab, and I don't know if you guys got to those before we had to go on break, but that's the little machine where you blow out, you breathe in and out, and then it provides the expiratory resistance and once again provides a PEEP. Okay, so all of those are great modalities. If this darn pandemic, you guys would have been in the hospital right now performing all of these. It's a very common modality that you'll use on the general care floor, all of those.